Hello, everyone. My name is Oriana Lowe. I am a pediatric dentist practicing in Los Angeles, California. Today, I will be giving a lecture on behavior management in pediatric dentistry, pharmacological concerns, part 1. This section is divided into 2 parts because of the length and the materials that needs to be covered. So we will begin by going over the goals. The goals of conscious sedation for the pediatric patient will be reviewed. Pharmacologic management of behavior for the patient, which includes oral, inhalation, intramuscular, and IV sedation and general anesthesia, will be reviewed. Understanding the importance of patient selection for sedation cases will be reviewed, and a review of the monitoring criteria and what to do in emergency situations will be covered. The objectives is to describe conscious sedation and its goals, to recognize anatomic and physiologic differences between the child and adult, to know the classification and mechanism of action of commonly used sedation drugs, to understand the criteria for sedation patients and their selection, and to eliminate or reduce emergency situations related to pharmacologic management. So what is conscious sedation? There are different types of conscious sedation. The first type is the minimal sedation. This produces a minimally depressed state or level of consciousness in which the patient retains the ability to maintain his or her own airway. They can respond to appropriately physical stimulation or verbal commands. Moderate sedation is a drug-induced state of consciousness during which the patients respond purposefully to verbal commands, such as open your eyes. This could be either alone or accompanied by tactile stimulation, such as a light tap on the shoulder or maybe a little pinch. There is no intervention needed to maintain a patent airway. Spontaneous ventilation is usually adequate and cardiovascular function is maintained. However, with deep sedation, the state of consciousness, this is where the patient cannot be easily aroused but responds purposefully after repeated verbal or painful stimulation. The ability to independently maintain ventilatory function may be impaired, and patients may require assistance in maintaining a patent airway with spontaneous ventilation. The goals of constant sedation is to, 1, facilitate the provision of quality care, to minimize the extremes of disruptive behavior, to promote a positive psychological response to treatment, to promote patient welfare and safety, and to return the patient to a physiologic state in which safe discharge, as determined by recognized criteria, is possible. All reflexes are essentially intact. In addition to guarding the patient's safety and welfare and minimizing physical discomfort and pain, the other purposes or additional purposes to conscious sedation is to control anxiety, minimize the site of local trauma, maximize the potential for amnesia, to control behavior and or movement during the procedure to allow for safe completion of the procedure, and to return the patient to a state in which medical supervision is possible. In contrast to the awake state, deep sedation and general anesthesia are defined as conditions of the patient characterized by an incomplete, partial, or total loss of protective reflexes. In addition, there may be a partial or complete loss of the ability to independently and continuously maintain a patent airway. Under these circumstances, the patient is non-interactive and does not respond to purposeful physical stimulation or verbal command. Many times the patient will drift into normal sleep. When this occurs, it becomes critical that the practitioner or the provider to assure that what is being observed is normal sleep and not something else. And this is routinely done by frequently arousing the patient. There are several requisites that should be satisfied when the use of conscious sedation is considered. One, the practitioner should possess a thorough knowledge of the agent or agents to be used and should formally be trained in the proper method of their administration. Two, the decision should be made based on a careful analysis of the behavioral profile of the patient, the nature and extent of treatment, and the risk to benefit ratio. And also, in regards to the family, the physical status of the patient, the capability of the family to meet the demands of extensive treatment, and the economic feasibility of alternative choices. Another requisite for sedation use is that the patient should be carefully evaluated to ensure that no condition exists that might alter the expected response to the sedative agent or technique and posing a risk to the patient. There should be a well-documented and informed consent. The office facilities should be such that a comfortable experience can be assured and the personnel is trained in techniques of monitoring a sedated patient. Mobile emergency medical services should be readily available. This is critical in the office before ever sedating a patient. Now, I wanted to mention to you the fatal trio. When sedating patients, there's always a risk. Adequate management to reduce the loss of morbidity and mortality must be adhered to. The core principles of rescue refer to the fatal trio. One is hypovolemia. Patients are MPO. They need to verify the guidelines for recommendations. Make sure the patients have not eaten or drank anything between the recommended time frame. Hypoxia. Recognize respiratory dysfunction and distress immediately. Hypercapnia. If hypoxia persists, hypercapnia will result in the patient being more prone to cardiac arrhythmias. Obesity also takes a place in the evaluation process. Lipophilic retention may be prolonged in obese children. Important factors must be considered when sedating. Know that the absolute basal metabolic rate values are higher than in lean individuals. Greater absolute oxygen consumption and CO2 production, and obesity is a multi-system disorder involving both the respiratory and cardiovascular systems. The discharge criteria is also critical before discharging a patient. You must maintain that the cardiovascular function is satisfactory and stable. The airway is patent and uncompromised. The patient is easily aroused and protective reflexes are intact. The state of hydration is adequate. The patient can talk if applicable. Patient can ambulate if applicable. And if the child is a very young or disabled patient and incapable, the usually expected responses, the pre-sedation level of responsiveness or level as close as possible for that child has been achieved. And a responsible adult is available to care for the patient. There are anatomic and physiological differences between an adult patient and a child patient. There are differences in size, weight, and age as a measure of maturation. It is less obvious but equally important are the differences in basal metabolic rate between the adult and pediatric patient. The basal metabolic activity is greater in children, which ultimately affects not only drug response, but also physiologic parameters. And because the oxygen demand is greater, but the alveolar system is less mature, the respiratory rate is far higher in children than in adults. This is a very important consideration when drugs that depress the respiratory system are administered. Variations in anatomy have influences on the patient's airway. Airway management requires different considerations in the pediatric patient as opposed to the adult patient. Narrow passage, nasal passages and glottis combined with hypertrophic tonsils and adenoids and enlarged tongue and greater secretions are characteristic in children. The airway of all patients should be examined prior to sedation. Patients with tonsillar tissue that occupies more than 50% of the pharyngeal space are at increased risk of respiratory obstruction, and alternative treatment options should be considered. Children demonstrate a reduced tolerance to respiratory obstruction. Thus, a sudden apnea is a greater concern in the pediatric group because the thorax is smaller with less expansion capability, and children have less functional reserve. Consequently, they are more prone to rapid desaturation when obstruction or respiratory depression occurs. For this reason, children with sleep apnea are not good candidates for conscious sedation. Here is a diagram of the tonsils on the left and the nasal cavity and epiglottis on the right side going down. And you see that from the nasal cavity going down, and it connects to the mouth, and the tonsils are right there, where just above the epiglottis. This is critical, and you need to pay attention to this area when sedating a patient. Picture of the thorax and the lung cavity, and again, you need to know your anatomy. A mention of the cardiovascular aspects of children. The CV parameters are different for children and adults. The heart rate is faster and blood pressure is lower than in the adult. Children are more susceptible to bradycardia with decreased cardiac output and hypotension. Unlike in the adult population, heart rate is the primary determinant of blood pressure in children. Compensatory mechanisms to maintain adequate blood pressure when the heart rate is depressed are not as developed in children. Thus, a decrease in heart rate leads to a corresponding decrease in blood pressure and tissue oxygenation. This concept must be well appreciated when giving drugs that depress the heart rate in the pediatric age group. Now, to mention about the action of drugs. The effect and duration of drug action is much more variable in children. For agents that are more lipophilic, retention may be prolonged, especially in children who are obese. For many types of patients, drug metabolism may be increased because of better peripheral perfusion in children. The onset of intramuscular administered drugs may be more rapid, and this is due again to the increase in metabolism and the better peripheral perfusion. Now, a mention of bioavailability. Bioavailability refers to the fraction of the dose of the given drug that reaches the circulation intact. The dose of unchanged drug that reaches the systemic circulation, by definition, when a medication is administered by IV, its bioavailability is 100%. So this is an important concept to remember. An increase or decrease in bioavailability directly impacts the oral AUC or total drug exposure. For low hepatic extraction into drug ratios, bioavailability is not affected by enzyme activity, hepatic flow rate, or protein binding. That's the oral route of administration is widely used, and more so with many of our practitioners in private practice. An IV sedation technique, by using that, you need to be specially trained. Drugs administered by mouth may vary in peak and consistency of effect. The operator cannot titrate the drug to achieve optimal effect, and if they do try to do this, it is dangerous. Recovery time may be prolonged because the drug is slowly metabolized. Now, a word of inhalation anesthesia. Nitrous oxygen is considered the most effective and readily accepted method of obtaining analgesia to minimize anxiety in the dental patient of all ages. Safe use of nitrous oxide oxygen entails the following: to make sure that you have a flush lever for easy and immediate flushing of 100% oxygen. The operatory must have a good cross ventilation with exhaust vents located near the head of the chair. A fail-safe system providing automatic shutdown if the oxygen level falls below 25%. This is critical, and many of our systems have to have, not many, but all of our systems must have this in case the oxygen level drops and the oxygen tank it runs out. The system will turn off. So some precautions that you need to know before sedating the child patient. Children have a reduced tolerance to respiratory obstruction due to an enlarged thorax with less expansion capacity. They have less emotional reserve. Children have a relatively large costo expiration volume. Pediatric diagrams are less capable of displacing large volume of vertical dimension. In the pre-op assessment period regarding the domains of procedural sedation, you need to consider the extent of treatment, the medication regimen, the age and parental expectations, and child temperament. All these must be taken into consideration before sedation. When treating a sedated patient, there are different ways of determining if the patient is breathing. This includes mirror frogging. Put the mirror by the nose, and if it fogs, he's breathing. Watch for chest movements. Listen for respiratory sounds with a stethoscope or precordial stuff. Brodsky scale. Now, this is very important to know and to keep in mind. This scale measures the tonsillar size. The Brodsky scale is considered high if it is a grade 4. The scale ranges from 1 to 4, 4 being the worst. Here we go. The scale 0, the tonsils have been removed. Tonsils hidden within the tonsillar pillars is a 1. Most of us are 1s. Tonsils extending to the pillars is number 2. Number 3, you have the tonsils beyond the pillars. And number 4, the tonsils are meeting at the midline, and this is dangerous. What is obstructive sleep apnea, or OSA? This is, OSA is currently being studied a lot today. It is a disordered breathing characterized by prolonged partial upper airway obstruction. Many more children and adults are being diagnosed with this. This could be a cause of snoring and disruptive sleep. It could be intermittent, complete obstruction that causes abnormal ventilation during the sleep periods. It occurs at any age and exists in 1 to 5% of all children. OSA can cause lowered oxygen levels in the blood, which is detected by the brain waking the individual up to facilitate breathing. Patient selection, and this is a very important aspect of sedation. No one technique or agent or combination of agents should be expected to be successful every time. One should choose the agent and technique that best fits the patient type as well as the nature of what needs to be accomplished. You wouldn't want to sedate a patient just because you're placing a sealant or a small occlusal filling. That is not acceptable. A thorough medical history is required to determine if a patient is suitable for sedative procedures. This, along with a recent physical exam, constitute a risk assessment or physiological status evaluation by the physician. Only patients who are categorized into ASA 1 are routinely acceptable as candidates for conscious sedation. Some children assigned to ASA 2 or 3 may actually benefit from this approach, but this must be determined in consultation with the physician. Generally, patients who are categorized into classes 3 and 4 are better managed in a hospital setting. Again, to remind everyone, the imperative for patient selection is first, do no harm. This refers to the safety of anesthesia and sedation practices. Keep that in mind. The ASA classification, as a review, is 1, a normal healthy patient, class 2, a patient with mild systemic disease, class 3, a patient with severe systemic disease that is not incapacitating, class 4, a patient with an incapacitating systemic disease that is a constant threat to life, and 5, a moribund patient who is not expected to survive more than 24 hours with or without surgery. And this patient, of course, you should not even consider doing any work. Patient selection and preparation. An informed consent is critical. This is the instructions to the parents. Information in written form should be reviewed with the person caring for the child and given to this person according with the notice of the scheduled appointment. This information should include a 24-hour contact number for the practitioner or dental provider. Written consent does not equal informed consent. The patient has to actually understand the treatment they are consenting for. Permission granted and full knowledge of the possible consequences, typically that which is given by the patient to a doctor for treatment with benefits, with knowledge of the possible risk and benefits. The patient or the guardian must know the risk and benefits of treatment. Every effort to ensure the patient understands the purpose, benefits, risk, and other options of the test or treatment must be reviewed. Written consent before starting must be obtained. Now, a bit about dietary instructions. Depending on the age of the child, there are certain restrictions for diet. No milk or solids for 6 hours for children 6 to 36 months old. Nothing up to 6 to 8 hours for children 36 months and older. Clear liquids up to 3 hours before the procedure for young children 6 months or older. Emesis during or immediately after a sedative procedure is a potential complication that can result in aspiration of stomach contents, leading to laryngospasm or severe airway obstruction. Aspiration may even present difficulties later in the form of aspiration pneumonia. The caregiver should be advised that on arriving home, the child may sleep for several hours and may be drowsy and irritable for up to 24 hours after the sedation. It is critical that the caregiver be on alert and be with the child at all times. It is important to stress the need for frequent observation, especially if the child is sleeping, to ensure an open airway. Listen for the air sounds, the breathing sounds, snoring. Look at the stomach rise and fall. And again, put your hand by the nose and see if you feel some air escaping through the nostrils. Following treatment, the child should first be offered clear liquids, not solids. Once solids are tolerated, there are no dietary restrictions. Nausea and vomiting may occur, especially when narcotics have been used. This may thus provoke and prolong delay before solid food is taken in. In this event, Special attention should be paid to the fluid intake to ensure adequate hydration. Little bits of liquid, little bits of food. Don't rush into it. The child will be okay. Documentation. Pre-procedural records should document proper adherence to food and liquid intake restrictions. The pre-op health evaluation, including the patient's health history and a complete physical assessment, along with the current weight, age, and baseline vitals. The name and address of the physician who usually cares for the child. A note as to why the particular method of management was chosen, the presence of the informed consent, and the delivery of instructions to the caregiver. Pre-instructions and post-instructions. Intraoperatively, the appropriate vital signs should be recorded, and time notations regarding the patient's appearance should be included in the documentation. The type of drug, the dose given, the route, site, time of administration should be clearly indicated as well. If a prescription is used, either a copy of the prescription or a note as to what was prescribed should be also a part of the permanent record. After completion of treatment, the patient should be continuously observed in an appropriately equipped recovery room. The patient should remain under direct observation until respiratory and cardiovascular stability have been achieved. The patient should not be discharged until the pre-sedation level of consciousness or level as close to as possible for that child has been achieved. At the time of discharge, the condition of the patient should be noted, such as alert, looking at mom, smiling, asking for something to drink, reaching the arms out to hug mom or dad. Sedative drugs may be administered by inhalation or by oral, rectal, submucosal, intramuscular, or intravenous routes. The use of combination of drugs and specific selection of routes of administration to maximize effect and increase safety, as well as maximize patient acceptability, are common. Use of nitrous oxide oxygen mix is often coupled with administration of an agent by other routes. Another practical and efficient technique is the time sequencing of a combination of drugs. The only classification of sedative drugs acceptable for administration outside of treatment facility are minor tranquilizers, such as diazepam or hydroxyzine. This would, of course, include patients for whom stress reduction would include the likelihood of complication. These children should be managed in close cooperation with the physician who usually cares for them. Sedation techniques include minor tranquilizers, do not include chloral hydrate or narcotics. The primary goal of these techniques is to produce a quiescent patient to ensure best quality of care. And although the presence of a compromising medical condition is generally a contradiction to sedation, some patients in this category may benefit from its use. A bit about nitrous oxide. Nitrous oxide is a slightly sweet-smelling, colorless inert gas. It is compressed in cylinders as a liquid that vaporizes on release. It is an endothermic reaction that pulls heat from the cylinder and environment, and consequently the cylinder will become cool or even cold when in use. The gas is non-flammable but will support combustion. It is the most frequently used sedative today. This is, when using nitrous oxide, oxygen, you must have an extra oxygen tank available. And you also should have a bag mask valve device in case the patient becomes hypoxic. Nitrous oxide analgesia contraindications include history of claustrophobia, COPD, and pregnancy. Before considering the use of nitrous oxide oxygen, certain parameters must be met. A flush lever for easy and immediate flushing of the system with 100% oxygen. Operatories must have a good cross ventilation, a fail-safe system that provides automatic shutoff if oxygen falls below 25% is a necessity. It should be audible and visual. The alarm should be activated automatically. Note that nitrous oxide is a heavier gas than air with a specific gravity of 1.53 and has a blood-to-gas partition efficient of 0.47. Nitrous oxide will become saturated in the blood within 3 to 5 minutes following administration and is physically dissolved in the serum fraction of the blood. There is no biotransformation, and the gas is rapidly absorbed by the lungs when the concentration gradient is reversed. Now, a bit about diffusion hypoxia. This may occur as the sedation is reversed at the time of procedure. The nitrous oxide escapes into alveoli with such rapidity that the oxygen present becomes diluted. The oxygen-carbon dioxide exchange is thus erupted, and the period of hypoxia is created. This phenomenon is reported not to occur in healthy pediatric patients, but to minimize this effect, the patient should be oxygenated for 3 to 5 minutes after a sedation procedure. Nitrous oxide produces nonspecific CNS depression. Although it is caused as an inhalation general anesthetic, it produces limited analgesia, and surgical anesthesia is unlikely unless concentrations producing anoxia are reached. Nitrous oxide is the weakest of all inhalation agents with a minimum alveolar concentration of 105. Note that the minimum alveolar concentration of an inhalation agent is a measure of its potency. The concentration required to produce immobility is 50% in patients. At concentrations between 30 and 50% nitrous oxide will produce a relaxed, somnolent patient who may appear dissociated and easily susceptible to suggestion. Amnesia may occur in some patients, but there is little alteration of learning or memory. It is not recommended that concentrations greater than 50% be used in the dental office. Nausea or vomiting is the most common adverse effect. Other contraindications include severe behavior problems, emotional illness, and uncooperativeness, the fear of gas, claustrophobia, maxillofacial deformities that prevent nasal hood placement, nasal obstruction, chronic obstructive pulmonary disease, pregnancy, and situations in which high oxygen is inadvisable. Chronic exposure to nitrous oxide, including recreational abuse, can over time produce neurotoxicity, impotence, and renal and/or liver failure. Leakage from open systems, such as those used in dental offices, should be reduced as much as possible. This can be accomplished by limiting the amount of mouth breathing by the patient and using an efficient scavenging system. The installation of a laminar airflow system is suggested in new office constructions, and dosimetry badges could be worn by office personnel if using nitrous oxide for 8-hour periods of time. Again, a fail-safe system that provides automatic shutdown if oxygen falls below 25% and is audible and visual alarms is highly required. There should be a flush lever for easy and immediate flushing for 100% oxygen, and mobile self-contained units are available. Again, operatory should have great cross ventilation, and exhaust vents should preferably be located in the ceiling as close to the head of the chair as possible. This gas must be vented to the outside. Here's a picture of an oxygen system. The technique, The bag is filled with 100% oxygen and delivered to the patient for 2 to 3 minutes, between 4 and 6 liters per minute before the nitrous oxide is turned on. The delivery tubes are usually tightened behind the chair of the patient when the procedure is begun. When the procedure is begun, the patient is encouraged to breathe through the nose. When the patient is ready and has a good feeling, they will feel a giddy feeling with the tingling of the digits. The eyes would take on a distant glaze. They may be entering what we call the laughing stage of analgesia, and this is why nitrous oxide is called laughing gas. And when they enter this giggy stage and the tingling of the digits, the procedure can now take place. And this is when local anesthesia or anesthetic can be given. Make sure an emesis basin is readily available in case the nitrous oxide causes nausea. Recovery for nitrous oxide is quick. You should be giving 100% of oxygen for 3 to 5 minutes with the patient in the sitting upright position to prevent dizziness on standing. So this concludes the first part of our sedation lecture.